next presenter from عين شمس University. دكتور احمد جمال موجود؟ موجود فين؟ اهلا وسهلا. انا كنت بدور عليك. يبقى next presenter دكتور احمد جمال patient customized breast surgery. اتفضل يا دكتور احمد.
Patient customized breast surgery. As we all know that breast cancer patient, breast cancer is second most common cancer in Egypt with 22,000 cases according to GloboCan 2020. And of course, it's the most common malignancy among females. And first common malignancy mortality among female with 9,150 deaths per year. There is difference between patients. Patients are not the similars. There is difference in medical background, like diabetes, hypertension, ischemic heart disease, smoking, atherosclerosis. Also, there is difference between patients in socioeconomic class. We have two main categories for operation. Either mastectomy with all its kinds, modified radical mastectomy, skin sparing, neck sparing, Goldilocks, and the conservative, either it's wide local excision or oncoplasty. Choice of surgical technique depends first on tumor factor, size, focality, skin factor, is it near from the skin, away from the skin, and the breast factor, size, previous operation. And the most important factor we are concerning in my presentation is patient preference plus safety. My presentation here like a poke. I want to think outside the box. I want to put patient preference in the first priority in my operation. And patient preference differ according to the factors which I mentioned. According to NCCN 2022, the most important goal for any breast surgeon is no ink on tumor, on specimen actually. Here just to remind that a multicentric and multifocality is not a contraindication for conservative breast surgery before I proceed in my operation, presentation. The absolute contraindication is radiotherapy during pregnancy, diffuse suspicious or malignant appearing microcalcification, widespreading disease cannot be incorporated by local excision. So multicentric and multifocality, if I excise completely, is not a contraindication for breast conservation. Discussion is a key for success. Discussion between the patient and doctor about what she aims, what she likes for her operation, and the safety and preference is a key of success. And always remember that every patient is a challenge, and every patient needs a new plan. There is no two identical patients. So upper outer quadrant masses are not dealt by the same way for every patient. Every patient has its own plan. Of course, we all know that upper quadrant is about 50 to 60% of all malignancy. Here is some of upper quadrant lesions and how we manage them. Here is a patient with a 5x4 cm invasive ductal carcinoma luminal AN0. Patient accepts post-operative radiation. Patient refused any operation in contralateral breast, and the mass is not a small. It's about T3. So here we go for inferior pedicle mammoplasty with minimum reduction. Even we don't perform the proper reduction for this patient. Here is the post-operative outcome. Patient is satisfied by this outcome, and I am satisfied as the patient is satisfied. Here is another patient, 42 years old, with two masses, 3x4 and 3x3, invasive ductal carcinoma, luminal AN1, received 6 cycles of neoadjuvant chemotherapy, and now she is seeking for operation. This patient have a small video for the operation. I'm just planning and marking the mass. As we all see, the mass is not that small. The mass nearly about 1/3 of breast. And here for this patient, we go for inferior pedicle mammoplasty, and here's the patient request for contralateral symmetralization because she has a degree of back pain from her breast size. Here is the immediate post-operative, and here is the pathology. I excise about 14 times 10 times 5 centimeters from the breast, and the masses was 3.5x3 and 3x3 and 1.5 centimeters apart from each other. All margins are free in this patient. And here is the 14 days post-operative. Same quadrant, same lesion, do different management according to the patient. Here is another patient with invasive ductal carcinoma, and it's very near from the skin. Even in the diagram of the picture show skin dimple, mild skin dimple. Here is the nipple is congenitally retracted. The patient asked for conservative breast surgery. She refused at all mastectomy. I go for this patient excision the mass and skin island, and I put a skin island from inferior pedicle based on inferior pedicle. So I make a combined operation with superior pedicle myoplasty and the inferior pedicle. I put a skin island to fulfill the gap, which is performed by the mass excision. Here is about 14 days post-operative. Patient is satisfied by the income. Here's another patient, 41 years old, 6 × 5 centimeter luminal B, received 6 cycles of neoadjuvant with not that good response from neoadjuvant. The 6.5 plus margins equal nearly hemi breast. Half of her breast is full of the mass. I go for this patient after discussion with her for mini LD flap. Here is the skin, here is the incision, at lateral border of the breast, crescent incision. We perform about hemimastectomy. Here is the LED flap, meaning from the same incision, not from pack incision. And here is how it looks like immediately post-operative. And here is about 5 days post-operative. Thanks to Dr. Reda, who was the lead of team in this operation. Dr. Reda. Another patient, 37 years old with invasive ductal carcinoma, and here the mass reaching the nipple and areola. And the nipple area show blood orange. So for this patient, the patient refuses mastectomy, and I go for this patient for wide local excision plus excision of the nipple areola complex, and I perform LED flap with a skin island to fulfill the gap. And here is the picture of the patient only 10 days post-operative. Another 33 years old patient with invasive ductal carcinoma for upper outer quadrant and another mass in lower outer quadrant. The patient here she asked for neck sparing mastectomy, nipple areola complex sparing mastectomy. I here go for a prepectoral implant wrapped with ultra pro mesh. Here is during operation, after evacuation of the breast is evacuated. Implant was put wrapped by ultra pro mesh, and here is how it looked like just 1 week, and here is 3 months post-operative, the same patient. Another 62 years old patient. This patient was diabetic ex-smoker, and she has upper outer quadrant lesion. Here I choose to go for only small crescent incision to excise the mass with minimal scar, just circumallular, and full free margins was detected by pathology, and the patient was satisfied by the income. Just to remind that multifocal and multicentric cancer, according to Yazan and his colleagues, he says that current evidence point to breast conservation as being safe for multilocal and multicentric breast cancer patients. This patient was very challenging. She was young, she was only 32 years old patient, and she received the neoadjuvant chemotherapy for left breast multicentric lesion, as is very obvious in the mammography, upper outer quadrant 1.4 times 2.5, another lesion as another non-mass enhancement about 8 times 7.5 times 6.5 in the left breast, another mass in the upper inner quadrant, plus the upper outer quadrant microcalcification of the right breast, proved to be DCIS by true cut biopsy. This patient was planned for bilateral mastectomy. The patient refused that decision and come to our unit, and we planned for conservation in the right side and skin reducing mastectomy for the left side, and we'll see the steps. Here is the power of the multidisciplinary meeting. We go for mammography, and here is very obvious the microcalcification. You see the two perpendicular planes. This whole area is full of microcalcification. We go for bracketing, 4-wire bracketing, actually not only 2. The radiologist performed 2-wire for identification of the mass, and he called me and I asked for 2 more wires. Here is the patient. The right breast, upper outer quadrant, diffuse microcalcification, barked by 4-wire. And the left breast is for skin reducing mastectomy. Here I go for a nipple excision as the microcalcification was reaching to the nipple. And I use Weiss pattern, as it's obvious from the previous picture. I use Weiss pattern. And the pillars, the inferior pillars here, medial and lateral pillars, I use it to augment the breast projection. And as the areola was very wide, I used part of the areola to recreate nipple-areola complex. That's for the right side. Going for the left side, unfortunately, I don't have a silicone at that time of operation. I only have expander. So I put the expander and inflate the expander during the operation. So I use it as a silicone. I put it subpectoral, and I use the lower part of the skin of the left breast as skin sling, subdermal sling, to cover the defect of the lateral pectoral defect. And here is how it looks like after inflating the expander and putting the sling. And here is how it looks like during closure with immediate nipple-areola complex recreation in the right side. And here is how the patient looks only 3 weeks after operation. Another patient, 54 years old female, known to have history of right breast invasive ductal carcinoma and underwent modified radical mastectomy. Now in follow-up, lower inner quadrant show microcalcification proved to be DCIS. Patient underwent wire bracketing under stereotactic mammography, followed by wide local excision. Unfortunately, in the paraffin, inferior margin was infiltrated by more than one focus. Patient refused mastectomy. This patient come to us with inferior margin infiltrated by DCIS. Although she is 54 years old and already underwent the contralateral mastectomy, she refused to do mastectomy. And here is how it looks like, how is the incision of previous operation looks like. It's traditional incision, elliptical incision over the brackets with excision of the lower inner quadrant. For this patient, I suggest to perform superior pedicle myoplasty. Here is how it looks like immediate post-operative, and here is how it looks like only 2 weeks after operation. The patient, although she has contralateral mastectomy, she was very satisfied by the result. This presentation is a poke. I want everyone to think outside the box. This patient went previous wide local excision in the right breast, and she has upper outer quadrant. We go for oncoplastic superior medial pedicle technique, and this is the difference between wide local excision and the oncoplastic procedure. Thank you.
Thank you very much. Is there any question from the Dr. عمرو اتفضل.
You have discussed a case with pod orange and nipple retraction, and you have performed double flap. You said that this nipple retraction is congenital, but if you showed us the photo again, it is very risky to preserve this nipple-areola complex. The nipple looks infiltrated.
I always exhaust myself in the investigation. In this case, we depend on, we go for contrast enhanced mammography and MRI with contrast. Both show that the nipple has no any dye in it. And the patient mentioned that the nipple retraction is since birth. The mass was in upper outer quadrant, in the pathway of the lymph node. And of course, there is mild edema in the areola. I see it. Even in this case, particular case, we went for, before neoadjuvant chemotherapy, we skin biopsy from the areola. It was negative for malignancy, because we tried to fulfill the gaps in this case.
Skin biopsy from the areola.
This is another
What
issue.
about
Skin biopsy from the areola is not significant for any reasons. We are concerning with the glandular tissue behind the areola.
Okay.
And
the contrast enhanced. The MRI with contrast show no masses, no dye reaching the areola nipple areola complex. We only have blood orange. So in the MDT, we asked the pathologist with us. He said just take a core biopsy from the nipple area skin and subcutaneous, and we will is it
Core
infiltration?
biopsy, not incision.
لا excision biopsy about 1 cm.
دكتور جمال يعني very good job. You are a brave heart. Most of your cases is, I think, locally advanced. Most of your cases is locally advanced. How frequent in these cases you are sending them to neoadjuvant? How frequent? Half of them, for example.
Most of the cases is
all.
after neoadjuvant.
So most of your cases is not responding to neoadjuvant.
As I mentioned, there's some responding and others not responding. Most
But
of the
they're
unit
still
A and
large.
B not responding.
Yes, okay. So you have a very good job for a sector of patient who is having a poor response to neoadjuvant chemotherapy,
yes.
and the patient is still asking for keeping the
Yes.
cells. This is clear to us now. And I think thank you for this sector of patient to give them a solution.
And if you notice, most of the patient in the early 40s.
لا هي انت جبت sector of patient هم
Yes,
Seeking to keep
seeking
their
for
adjuvant.
conservative, refusing mastectomy.
very good job. Thank you. سؤال أخير. كده وضحت.
السكين اللي فيه بيود اورانج فانا I will spare the skin with edema او بيود اورانج. Is it enough to take random skin biopsy to be sure that there is no tumor lymphatic obstruction?
We have a huge debate about Bod orange, and we divide it into 2 parts. Bod orange just above the tumor, and Bod orange away from the tumor. We found plenty of cases when the tumor or when the mass was in upper outer quadrant, especially in the upper outer quadrant, in the pathway of the lymphatics, there is Bod orange in the neighboring areola. And we have always these thoughts: is it a permeation, lymphatic permeation, or just lymphatic obstruction? And we found in many cases we go for mastectomy or we go for excision of the neighboring areola complex, and the pathology, the final pathology, the paraffin is free. In very selected patient, especially those who refuse the mastectomy, we go for a skin wedge biopsy before neoadjuvant. Skin biopsy from the Bod orange in these circumstances, away from the site of the tumor, when the tumor is upper outer quadrant, when there is no dye, when there is no obvious dye in CISM or MRI. I put many obstacles. And then I go for biopsy prior to neoadjuvant and analyze the pathology. If it's free, it's free.
Okay, thank you, Dr. Ahmed. For the sake of time, we will move now to the next speaker.
Thank you.
Dr. Karim Fahmi, who will talk about the role of